The pelvic girdle, or hip girdle, consists of two hip bones. They're also called coxal bones. Cox means hip, or pelvic bones. The hip bones unite anteriorly at a joint called the pubic symphysis. This is the location of the pubic symphysis. Posteriorly, the two hip bones are joined via the sacrum. So recall that the sacrum is part of the axial skeleton, but the sacrum is the foundation of the pelvic girdle. It's often known as the keystone of the pelvic girdle because it holds the hip bones together. So what we see here are the two hip bones. We notice that there's a joint between the hip bone and the sacrum known as the sacroiliac joint, often referred to as the SI joints. And then anteriorly we have the pubic symphysis, a fibrocartilaginous joint. The femur is going to articulate with the acetabulum. Acetabulum means cup-shaped. That is the socket for the ball and socket joint, known as your hip joint. We also note that the hip bones have this flared region known as the ilium. The anterior region is known as the pubis, and then the inferior regions are known as the ischium. That will be better noted on another picture. This is a table showing some of the differences between a male and female pelvic girdle. And it's largely based on the fact that females give birth and males do not. But you'll notice that there's an area called the pelvic brim or inlet, and we often look at that as being quite a bit different in a female versus a male. Notice here we suggest that the female is wider and more oval. The male is narrow and more heart-shaped. Another difference is what's known as the pubic arch. A female pubic arch is typically greater than 90 degrees. A male pubic arch is less than 90 degrees. Some other differences: male bones tend to be heavier and thicker than female bones, so you also see that with the pelvic girdle. The location of the acetabulum is slightly different. In females, it's a bit smaller and faces more anteriorly, where in males, it's a bit larger and faces more laterally. But I think if you look at two pelvic girdles, you will definitely notice the difference between a male and a female. This is a lateral view of a single hip bone. You'll notice laterally you would see the acetabulum, but what this drawing will show is the three regions. These three regions used to be separate bones. At birth, they are three separate bones that have to fuse together to form the hip bone. This region, this more superior, larger region, is known as the ilium. The posterior inferior area is called the ischium, and then the anterior portion is known as the pubis. The ilium has what's known as the iliac crest. That is what you would feel if you put your hands on your hips. There is a notch for a large nerve known as the sciatic nerve. There's a spine called the ischial spine. There's a tuberosity. This is this rough surface. You actually sit on your ischial tuberosity when you're sitting in your chair. This shows the difference between what we would call the true pelvis and the false pelvis. There's an imaginary line that was drawn at the top of the pubic symphysis to the top of the sacrum. This is the sacrum. Above that imaginary line, that's known as the false pelvis. Below that imaginary line is what we call the true pelvis. Next, we are going to move into the thigh and learn the femur. The femur is the largest and strongest bone in the human body. All the weight bearing down from the torso enters the two femurs. So the femur or thigh bone at the proximal end is going to articulate with the acetabulum using the head. There is a neck region distal to the head. That neck region is what typically might fracture in someone with osteoporosis. Distal to the neck are the trochanters. Trochanters are projections that allow muscle attachment. We've got a lot of muscles of the thigh, of the buttocks that move the femur. Those muscles need to be able to attach and hold on very strongly. So there are two large structures. One quite a bit larger, known as the greater trochanter, situated more laterally. And then the smaller, lesser trochanter is projecting more posteriorly. This is the posterior view. So you have the head, the neck, the two trochanters. We move distal down the diaphysis, and we get to condyles and epicondyles. The condyles are what actually form the joint with the tibia. The condyles are large, round, smooth surfaces covered with cartilage, forming that knee joint. So you would have lateral condyle on the lateral side, medial condyle on the medial side. Above them would be epicondyles, much like we have in the humerus. These epicondyles are the location of collateral ligaments that stabilize the knee joint. Next, we have the patella. The patella, also known as your kneecap, is the most commonly bone associated with sesamoid bones. A sesamoid bone is a bone that is buried within a tendon. So this kneecap is encased in a tendon known as the quadricep femoris tendon. The patella or kneecap has a base that is the more proximal end or surface. The more distal end is known as the apex, kind of points distally. And then the posterior surface has a large articular surface in order to form a joint with the femur. The patella only forms a joint with the femur. It does not make direct contact with any other bone, not the tibia nor the fibula. And as you can hear, my dog is barking in the background. So we will end this lecture and pick up with the tibia and fibula on the next lecture.